This slide's presentation will provide an overview of the different prosthetic components that are involved in donning and doffing a prosthesis. Overall, you're also going to learn about different suspension systems that can be used. And as previous slides that I've done for this section, it's going to be back and forth between myself and Dr. Ustall. As I talked about previously, a prosthetic is attached to the residual limb via something known as a socket. So the residual limb sits down in the socket, and that socket is typically composed of some sort of fiberglass component or lightweight carbon fiber hard shell. Okay, that hard shell doesn't come in contact with the residual limb directly. There needs to be some sort of socket interface that resides between the socket and that residual limb. Typically, the first socket interface that you might see is some sort of gel roll-on liner. Okay, a gel roll-on liner is shown on the right side of the slide at the very top. Those are just different kinds of roll-on liners. They can be silicone, urethane, usually a squishy plastic. They provide some sort of cushion and oftentimes suspension for the residual limb into the socket. Okay, so the liner goes on first, and then on top of the liner, if the person needs to adjust the fit of their residual limb, who's with the volume, remember, will change during the course of the day, they can do that with something known as a sock. Okay, let's talk first about the gel roll-on liners in the next slide. Like I said, different kinds that you will see. C is more of a suspension system. B is more of a pin system. You can see the pin down here at the bottom of the liner, so it's actually attached. That's how that person is going to be physically attached to the socket. And A is more of a foam composite. Okay, so those are different kinds of gel roll-on liners. The gel roll-on liner goes on first, and then the person can add some socks. Socks can be wool, cotton, lycra, silver, in case the person's having some sort of infection or needs an antibacterial. Okay, the sock is something that goes on top of the liner. Okay, it's for added cushioning as well as volume management. So as that residual limb changes in volume during the course of a day with activity, that person can add or subtract socks. The socks come in 1-ply, 3-ply, 5-ply. 1-ply is a really thin material, and then 5-ply is going to be the thickest. So you can add just 5, 3, and 1, so that ends up being 9-ply overall. And you can adjust as many times as you want to have the socket with a little bit better fit. If that patient is actually using more than 10-ply total, it's time to talk to the prosthetist about the fit of the socket. They might need a new socket. Okay, here's a nice video with Dr. Ustall talking about socket residual limb interfaces.
It also provides a way of holding on to you, and that holding on process is called suspension. So sometimes the interface material gives you cushion and suspension together. Sometimes it's two totally separate pieces. So we have several different materials that we might use as the soft interface. We have used a variety of gel materials recently. These gel liners can look like this, where they might be a color inside. Different colors. They come in different thicknesses, 2 millimeters, which is about 1/8 of an inch, up to 9 or 10 millimeters, which is almost 1/2 an inch. But the thicker you make the gel, the heavier it gets, and the harder it is to bend the knee. So we have a variety of selections from many different companies. They also have different density, meaning some are softer, some are harder. This one comes what they call pre-flexed. It's bent a little bit, so when you sit down, it doesn't bunch up quite as much behind your knee. So gel is one of the most common interface materials that goes directly onto your skin. And the way the gel goes on is you turn it inside out, and then it goes directly against your skin, and then it rolls up. Now historically we also had other ways of providing soft interface. We have also used soft foam materials. This is a maybe 3/16 to 1/4 inch thick foam that's shaped exactly to your leg, and this would actually go inside of the socket, providing a soft interface. Sometimes we even use a plastic material as an interface between your skin and the socket. Now the plastic is not very forgiving in the sense of cushioning, but it is very adjustable. So if we anticipate that your limb is going to have some changes, either steady changes or up and down changes, this kind of a plastic material will accommodate for adjustments. You can glue, grind, and put stuff on here, just like the foam is easy to adjust. The problem with the gel liners is that you can't make any adjustments at all. They just stay the same thickness. You can't glue anything to it, you can't grind anything. Now, you as the patient will also have another way of creating some adjustments, and that's with a variety of socks that we give you. And these also provide interface. These socks come very thin, what we call one ply, almost like a t-shirt material. They can come with or without a hole in the bottom, and that will have to do with the suspension we'll talk about in a minute. Then we give you thicker socks. This is almost more like a sweatshirt material. Typically we give you 1 ply, 3 ply, and 5 ply, thinner to thickest, and then you can match them up to give any number or any amount of thickness. When your limb shrinks down a little bit, you can add more socks, so it's still a nice snug fit. If your leg swells a little bit, you can take away some socks. So realistically, this is the adjustable part that you can mess with. Now, realistically, the socket itself is designed to be exactly like the shape of your leg. So if your leg changes dramatically, you may actually have to have a socket change.
Okay, that was what you essentially have to know about socket residual limb interfaces. Now we're going to move into something known as socket suspension systems. And the ones that I'm going to cover in the next couple of slides are listed here, where we have cuffs, belts, or straps, or something called a lanyard system, an external sleeve, a pin lock, and a seal-in, which is a suction with a liner. Okay, kind of old school, not used as much later on once the person is properly fitted with their socket. You have cuffs, belts, and straps. On the right-hand side, you can see a picture of a cuff and a belt in a person with a BK. And this is going to be a transtibial amputation up here on the top right with PTB sockets. PTB stands for patellar tendon bearing sockets. We'll talk exactly what this means in a few days when we cover types of sockets for both transtibial and transfemoral amputations. With transfemoral amputations, this can be a primary suspension system, especially if an individual has a short residual limb or if they have a lot of change in volume in the residual limb early on. Disadvantages are listed here. It's going to be warm, it's uncomfortable, there's actually minimal suspension. It might move around when the person is sitting, and since there's minimal suspension, it can cause bruising or chafing. The next kind of system that we're going to talk about is a lanyard system. Okay, lanyard system is really easy to don or put on. Okay, it provides a secure suspension system and decreases rotation of the socket. It's simple, reliable. Disadvantages to a lanyard system: you need some hand dexterity and strength, and a liner is needed for the suspension. So you have two different components here. Let's go ahead and watch this short video on donning using a lanyard system.
When we're fitting the above the knee or transfemoral patient with a lanyard system, that's basically a liner that has a strap that is a Velcro-based lanyard strap that will attach and hold suspension from below the socket. So how you put this on, you'll notice that the process has cut it lower on the inside than the outside. That should be the groin side. You want to turn the liner completely inside out and completely flush at the bottom. Remember, there can be no air pocket here at the bottom. If you put this on with an air pocket, you create a hickey effect at the bottom. You can create a lot of skin damage. So you always want to flush it all the way out, either if the therapist is doing this or the patient. You make sure that that lower side, it's cut up higher, I should say, is on the inside. Stick this right on the end of the residual limb, flush to it, and again, roll it up. What you're looking for is simply keeping your hands flush. Don't grab it with your fingernails. You can cut holes in the liner. Just kind of use the flat of your hand to slide it up the leg. It's going to want to work its way up there. When they're new, they're a little bit stiffer and don't roll quite as easily. But once we get up about this far, Percy, go ahead and help me out and pull that guy all the way up around. There you go. And you have to kind of lift up to get it to clear the base, and then pull the shorts out so that you're not got everything caught up in the socket. There we go. And bring it around the front. Now we've got our lanyard strap. We want to unhook that lanyard strap. We're going to take our prosthesis at this point in time, and you'll notice in this prosthetic we have socks. That means if the patient has got a fit that needs a sock, you need a particular sock that has a hole built into the bottom of it. What you're going to do is take that sock, put your lanyard strap through it here, and pull it up flush. Percy, if you grab and pull that sock up flush, that'd be great. And we get that level, and you pull it all the way to the top because you want your socks to come up over the brim of the socket. That also keeps some of the plastic from rubbing on your skin and also keeps any wrinkles out of the socket or the liner. From that point, the lanyard strap goes down through a hole that the prosthesis is cut in the bottom of the socket. Again, you do this yourself. As a patient, you're looking down through and pulling the leg through that, or the lanyard through that hole. You're going to pull that leg up as best you can into position. And it doesn't have to be on perfectly, just close. And so you get to a position where you pull up the best you can, give it a little tug down. And at this point in time, that thing is not on all the way, but it is on solid. You could really drag someone across the clinic floor with it in this position. You don't need to do that. Now, what you're going to do is bring up a walker in a position here so the patient's in a stable position. I'm going to let you, Percy, go ahead and stand up when you're ready. There you go. And lean forward into it. Beautiful. From that position, he just brings the prosthetic back and settles his weight down into it. I'm going to adjust, and he can do the same with just socks and liner, or pull the shorts out a little bit. But you'll notice what's happening here is this lanyard strap will start to become a little bit loose. So you grab that lanyard strap and give it a bit of a tug down, and that pulls you in a little bit tighter. Notice when you pull on the lanyard strap, you pull from the bottom of the strap. You don't pull from the D-ring, this ring up on the top, because you'll pull the rivet right off it. You always pull from the bottom, come through the D-ring, and take up the slack. Now that makes a good solid fit. Now Percy, show them how you would do that yourself if you adjust that strap.
You basically, well, in terms,
There you go, right there, just showing them how it's done.
just
There you
come
go.
down.
Here you go. Notice how he's balancing with one hand, using one hand to pull it through, taking up the slack,
Right.
and he's got a good solid fit. From there, the shorts come out, and he's in a stable position.
Moving on to the next kind of suspension system, here we have an external sleeve. An external sleeve provides an airtight seal. This is just going to be one of those silicone gel liners. Because there's an airtight seal, it's going to reduce something known as pistoning. And pistoning is nothing more than that residual limb coming up and out of the socket every time that person goes into swing phase, and then pistoning back into the socket when they go into stance. These sleeves are flexible, allow the knee to bend. It also has a cosmetic appeal to it since it covers the top edge of the socket. It's reliable, relatively inexpensive. The problem with the external sleeve is that at the very bottom of the disadvantage is a hole in the sleeve can lead to a loss of suction. Okay, and the hole can be due to increased wear. So over time, the more the person wears the sleeve, it can be reduced as far as its ability to provide that airtight seal. You do need some hand dexterity and strength. And if the person has the sleeve touching their skin, they can get an irritation or they can have some abrasion due to the presence of the external sleeve. Let's go ahead and watch this short video on donning a prosthesis using an external sleeve.
All right, now we're going to be talking about fitting the below the knee or transtibial amputation. and with a transtibial or below the knee socket. In this particular system, we're going to use a liner system with a sleeve over the top of a socket. So to get started, what you want to do is roll this liner all the way out, right? So there's no wrinkles and no gap here at the bottom. Really important on these issues as well is the hygiene of these liners. You want to clean them every day. It is very easy to get a contact dermatitis from these. And you want to clean the inside. Don't get the outside wet. If you get this nylon material wet, it'll smell and it will stay pretty smelly. So if you wash it right in the sink like I'm holding it now, let it rinse off completely. Mild soap, no deodorant, no smells or perfumes or anything like that. Lemon Fresh, just the most simple of soaps. Turn it inside out, hang it on a stand or lay it out, but don't ever lay it down with this inside material touching. Anything that it touches, cat hair, dog hair, newsprint off of newspaper, everything will be picked up. And then that will be a problem with putting it into the limb when you put it on or push it into your skin. So you turn this all the way inside out, make sure that there's no air gap. You're going to put it right on the end of the residual limb. Notice I'm using the flats of my hands, not grabbing with my fingertips. And I'm just sliding my hands towards her. As I do that, the device or the sleeve basically wants to pull itself on. This one has some wear, so it's going to roll on easier. A new one, you have to put a little bit more effort in to get it to roll all the way up. At that point in time, you just want to make sure there's no wrinkles and no air pockets from top to bottom. And the thicker side of the liner should always be in the top and the thin on the back side. That means it'll bend easier without pinching behind the knee. If the patient needs socks, and in Carol's case, we need that, so we're going to put a sock over the top. With socks, it's important to realize these are Lycra-based. So this is a 3-ply sock. But if you yank it hard enough, you can turn it into a 1-ply sock. So you want to keep it a full 3-ply sock by pulling the wrinkles out, but not stretching or yanking on it. That way it gets the sleeve solid with the sock over top of it with no wrinkles. The next issue becomes the sleeve over top. This is the liner, the sock, and now the sleeve. With the sleeve, what we want to do is we want to put it into a position where it has plenty of contact on the socket. That means it's well connected on the socket and plenty of material to maintain position and create that vacuum or seal to the skin. You roll the outside down, and when you roll it down, you always want to roll it down past the back wall of the prosthetic socket. If not, that will pinch or catch on the way on, and then you may lose suspension or be just very uncomfortable as well. From this point, we take our socket and simply slide it into place with the kneecap sitting right in the center of the groove. So bend your knee a little bit, Carol. There you go. And that kneecap should sit in the middle. I don't want to put that on an angle in any way. That's going to be uncomfortable. Directly in the center of the groove. Now, with a new patient with a lot more soft tissue or more swelling, you have to take your time a little bit to work the socket into place because it will hold and maybe hang up somewhat. Once she's in there in that position, you're basically going to do the same idea, the flats of your hands to slide the liner up onto the residual limb. Now, here we have a little bit of the liner underneath catching. And what can help that is ask your prosthetist to put a little bit of prosthetic tape right around the top base of the liner to hold it down, and then it won't adhere or stick to the liner as you're rolling it up. So we get this position, we roll it right to the top. Now you'll notice here that I stopped rolling it up right at the top of her liner internally. So as I pull this sleeve up, I want to make sure when I get to that point, I have about, again, 4 fingers of width for this liner to make good contact, or sleeve, excuse me, good contact with the skin. So at that point, I'm just going to roll that up, make good contact with the skin, and bring it all the way up. Now, at this point in time, you notice that there's no wrinkles all the way down, and tension-wise, that is locked onto her residual limb and all the way down. And she can bend it, right, into position, but that gives it a good, stable base.
The next suspension system I'd like to talk about is a pin lock system. And this is one where on the end of the gel liner that the person has put close to their skin, they have a physical pin sticking out. And the advantage of using a pin lock system is that there's a mechanical lock with auditory feedback. So, for example, when the person puts their gel liner on with the pin on the end, they hear an audible click, and the number of clicks will tell them how far they're in the prosthesis. It's really easy to don and doff, and the person can do it in sitting. And most importantly, it's pretty forgiving with volume fluctuations because you're not relying on a real tight fit with the socket with a pin lock system, because it's that pin actually engaging with the prosthetic that causes the attachment of the residual limb to the prosthesis. Disadvantages. One of the big disadvantages is it can cause skin breakdown. So if that pin is being pulled down on the liner, you can actually have some irritation on the end of the residual limb. You should know that newer liners are reinforced with a matrix to help avoid this. Okay, there's a lot of wear and tear on the liners, and if the pin isn't properly aligned in the prosthetic, the locking mechanism won't be engaged. And if the person is not able to bend down or they have poor eyesight, then they might have difficulty with the pin lock system. Let's go ahead and watch this short video on donning a prosthetic using a pin lock system.
All right, now we're fitting the below-knee amputee or transtibial amputation with a silicone suspension system and a pin. That means we have a roll-on sleeve that has a pin that engages audibly down into the bottom of the socket. This is helpful for patients to know how deep they are. They can count the clicks and determine the depth they are down into the socket. With a system like this, much like any other liner suspension, you want to roll it inside out. You always want to keep this very clean, top to bottom, and make sure, again, when you clean it, you don't get the nylon side wet or it will smell. Usually come in here, grab the pin, hold that under the water. You can rinse it really good, inside out to dry it. Don't ever lay it down like this. If you're going to lay it down anywhere, roll it back right side out. At this point in time, our key is that we have to have the pin become an extension of the bone of her leg. So if you put that on in a position too low and you start to roll up, you're going to see that pin is not facing directly out from the end of her leg. It is not going to engage well in the housing. This sounds simple, but it's a difficult thing for patients to always get that pin right. So what you're going to do is put that and try and get that pin as a direct extension of the bottom of the leg. And again, using the flats of the hands, not the fingertips, just slide that liner all the way up. If we have a good position, we have the pin coming directly off of the end of the limb. Before you put any socks on is a good time to check and see if you generally have it right. If you do, you can hear those clicks. It is clicked into place. That means we do have the sleeve in the right position. Once you put the socks on that she normally needs to be able to walk, it's going to be harder to get it to engage. So a good way to check your alignment is just slide it on first. She uses a 5-ply sock. Remember, with our socks, they can come in 1, 3, 5, 2-ply, whatever. This basically stands for 5 1-ply sock. So it is a thicker sock that has a hole in the bottom. Now, why is that important? Because if you put this prosthetic on with the pin pulling through sock like this, it will sometimes go down in and engage, but it will not come off. At that point, you become locked into the socket. You have to contact the prosthetist to have the prosthetic device taken apart from underneath to get out of the socket. So it's really important to make sure that if you put a sock on over top of a pin suspension, that the pin clearly and completely is free from the bottom of the pin. Now, in an absolute difficult situation where you can't get to that prosthetic limb maker, what you can do, and it is possible, that if you can take warm water and pour enough warm water down inside this liner, and you get enough water in there, you can slide it off. It's like being extremely sweaty all the way around. It takes a lot of water, a lot of patience, and a lot of time. So and that way you can get it off without having to get the pin disengaged from the sock. But to never make that mistake is the best way, and to make sure you always have the patient come down, put their hand down, and just check to make sure they feel that pin is completely free from the sock. Nothing to get caught up in the housing. From there, we don't have any external sleeve at this point in time. All the suspension is going to come from within the socket. So in this position, we're here. Kneecap should be in the center of the horseshoe in the front. Relax that knee a little bit. Most patients want to stiffen the knee up and become real stiff and tight. That causes the leg to expand. And then it becomes a bit of a Chinese finger torture. The harder you press, the more it does not want to engage. But if you can get them to relax that leg a little bit, let it bend a little bit, then we can get it down, and you can hear that engagement. That's starting to click in. There's a click. So now she's engaged. One click means it's not coming off. You can pull, it's not coming off. And the rest of it can come from pressing in or when she stands up to click in the rest of the way. So here we let that knee bend a little bit, try to be relaxed, and give a little more press to get down into the socket. If she's doing that herself, she's going to bend her knee. She can put her hands, and go ahead and do it, Carol, as far as pressing down in. There we go. So then that's down in and clicked into position. And she's locked in. If she got up and started walking around, this leg would click in a click or two deeper, and that would be at the base. It's a fairly short pin system. Now, the big key then is she is locked in. How does she get out of it? At that point in time, on the inside wall, there's going to be a button. Sometimes there's a cosmetic cover where you have to feel for that opening, but on this one, you can see the opening. All Carol has to do is press on that button and lift her leg up, and the pin comes directly out.
And finally, we have the last suspension system to talk about, and this is known as seal-in suspension. Advantages of seal-in suspension is it's going to provide even pressure throughout the socket with a nice secure fit. And that person's really going to feel like they're part of the prosthetic. You can don it in a sitting position, and even if that person is having small volume fluctuations, you're still going to get a really good fit. Disadvantages, this is going to be the most expensive of the suspension systems. There's a lot of wear and tear on the liner, and if that person is still having significant volume fluctuations in their residual limb, they're not going to get very good suspension. Requires some good hand strength and dexterity, as well as there's a lubricant. So this is something that person has to have with them in order to don the suspension properly. Let's go ahead and watch this short video on donning a prosthetic using a seal-in suspension.
All right, what we're doing here is fitting the above knee socket with a seal-in system. That's a system that has a roll-on sleeve and a gasket built into it. The gasket will seal to the prosthetic socket, and that gives us our suspension. There's no need for a strap or pin in this type of system. When you're donning a liner, it's really important that you turn that liner all the way inside out to start with. And you're not going to come down and leave any space. You want to pull it all the way inside out until it flattens out completely. At the second point, you're going to look and see that it's been cut by the prosthetist lower on one side than on the other. So you want to make sure that is going to go into the groin side. So you flush this out completely. You're going to put that right on the, bring it down a little bit, right on the end of the residual limb. And basically, as you come up, it's going to want to drag itself or pull itself up the leg. And that's all you're doing is you're pulling that and sliding up. To the patient, it's the same way. You notice I'm not using my fingertips and yanking on it. I'm basically just using the flat of my hand and letting it roll up. Very large shorts are helpful in this area so that you have room to work, and we'll pull it all the way up. So Percy, if you want to go ahead and help me pull that all the way up into place. And a lot of times with the chair, you have to kind of lift up a little bit to get the base all the way underneath and bring it all the way around. Go ahead and bring your leg all the way down. There we go. And we flush it all the way out. That way we know the socket's going to sit right in the right position. Perfect. Now the gasket here can turn inside out, and if the patient needs, you need special socks. These are socks with a wide open end, And what you're going to do with this sock is put it over top of the liner, come above the gasket here, but pull the base of the sock right down to the liner or the gasket and pull it over top. This holds the sock down in place, and then we would roll the sock all the way up flush before putting the prosthetic on. In this particular case, the patient doesn't need this, so I'm going to take it off, but just showing you how that works. And we'll take this off and set it aside. Now, when the gasket is in place, it's lying flush and flat in this direction. And what you need is some sort of sanitary moisturizing stuff. Purell or whatever the version you need or have is fine. And you want to get the gasket fully damp, all right? Any excess on your hand, you want to go ahead and wipe in the socket so that it will slide down in. If not, it's going in here. Then you have a fairly time sensitive. You want to go ahead and get the socket into place and begin to slide it. Don't stand up. We're just going to slide it into place the best we can to begin to get that pressure down in there. Excellent. And when we got it in that far, and that's far enough to get a basic seal, you can bring a walker around, whatever the patient needs, and go ahead and stand up for me, Percy. It comes right down into it. There you go. And loads it, puts the pressure right down on it. Now it's a one-way valve. That means it's going to start expelling air immediately. But if you press on that valve, you'll also get more pressure and more air coming out. So what patient does is go ahead and show them what you do, Percy. You put the pressure on the sock. There you go, on the socket. Press on it and press down into it. And you'll literally hear the air coming out of it. And you want to do that. You want to evacuate all the air out of the base of the socket until the residual limb is sitting flush down into the base of the socket. Many times, once he does this a little bit, he may have to walk a few steps, get around, and then try that again until it settles all the way down in tight. So he's got a very snug fit, and that's what you want, to have a good solid fit moving forward. From there, you just make sure shorts are pulled out from the socket because they many times will hang up and give him room to be in a good, stable position.